Welcome to the webinar. Tonight's topic is on ultrasound scanning, some tips and techniques in the scanning of ankle and elbow. So I'll talk briefly about elbow. I have a couple of slides, and I have more slides on ankle. Like I said in my email, some people had some difficulty in these two areas, so I thought I'll just bring some slides on those areas, and maybe that will help you in scanning those structures better. Okay, let's go next. All right, so let's look at elbow. So here on the left side, you're looking at complete checklist, and this is based on one of the reference which you can see on the bottom of the screen. Like you in the complete MSKUS code, which is 76881, which is complete examination of the extremity. When you examine or scan a body part or a joint region, you have to examine anterior, posterior, medial, and lateral part. And so in this checklist, as you can see, the areas are divided into anterior, lateral, medial, and posterior. Doesn't mean that they have all the structures on the anterior, posterior, medial, or lateral aspect, but they have important structures. Like on the anterior side, they have distal biceps tendon, brachialis tendon. We rarely image brachialis tendon. It's not a common structures to get involved, or doesn't have as many pathology of that tendon, but they have it here. You don't need to image everyone's brachialis tendon. Median nerve on the anterior aspect, anterior interosseous nerve. Now, I think the most important structure for a regular scanning of elbow is anterior elbow joint. That's the most important one to rule out any joint pathology. And distal biceps tendon would be another one after the joint. And then median nerve, when you're looking at anterior aspect of the joint in short axis, you're also looking at brachialis muscle and median nerve and radial nerve on the lateral side. So that includes other structure too. Now going on the lateral side, common extensor tendon. It's a fairly easy structure to image, but many people have difficulty with that. And then I'm going to show some images and anatomy images, especially to emphasize why you need a very important part of that area. You have to have the bony landmark to be able to image the common extensor origin well. So when you're scanning common extensor origin, you can also scan collateral ligament, lateral collateral ligament. And on the lateral aspect, the other structures are radial nerve, posterior interosseous nerve, which you can image when you're imaging anterior elbow. So there is no, like, sometimes you are on anterior aspect of a specific joint, like for example in elbow, and you can see some structures which are on the lateral aspect. So there is no defined rule what structures and what aspects or how many scans you have to do, but just know that you have to evaluate the joint in anterior, lateral, medial, and posterior aspect to qualify for 76881, which is a complete ultrasound examination. Now on the medial side, you have common flexor tendon origin and medial collateral ligament, anterior band, most commonly affected. Now on the posterior side, we have triceps tendon, and they have included ulnar nerve on the posterior. So this is again this is a little bit different than AIUM guideline, because ulnar nerve is considered a medial structure, but it's actually posterior medial. That's why they have included ulnar nerve on the posterior elbow, one of the structures on the posterior elbow side. So this applies to every joint, not just elbow joint. Any joint that you're evaluating and scanning, make sure you check all aspects of it. Okay, now going next to elbow joint, when you're examining joint, especially if you're suspecting someone with joint pathology, you're looking at their joint on the anterior aspect, posterior aspect, the recess, ligaments, and capsule. So here in this figure, On the left is the medial aspect of the elbow. On the lateral side is the lateral. On the right side is on the lateral side of the elbow, lateral aspect. So the red here is ulnar collateral ligament, and the yellow here is radial collateral ligament. Blue is annular ligament, and or green is the joint capsule. So joint ligaments are not very like they're more as a they connect bone to bone, and many times when you're scanning, you may not be able to see the ligament as a very well defined, and that's because some of the ligaments have fan shaped, so they start as a cord-like structure and they spread when they're attached to the other side of the bone. So as you can see, ulnar collateral ligament here, you have anterior band, posterior band, and the oblique band. If you look at anatomy image or cadaver image, you will look at them, and it looks like a continuation. So there are no separate. It's not like there's a separate band. If you look at nicely color coded ultrasound or anatomy images, you will see a very nicely defined anterior, posterior, and medial. But it's a connected structure, and a part of it is fan shaped. So you can see it as a continuation from anterior to posterior aspect. And when you're scanning, it's good to know this. This helps you in scanning, getting better scans when you know the details of the anatomy. Now, on the lateral side, you have radial collateral ligament, and that has attachment to the annular ligament. Joint capsule, again, that blends. You don't see it when you're evaluating the joint. You're also seeing the joint capsule. When there's fluid, it gets lifted up and you see it much better. So whenever there's fluid, it's a better contrast and you can see it much better. Now let's look at some of the images on the anterior aspect of the elbow. So this is what you want to get when you're scanning anterior elbow joint. So you want to see the bony landmarks, which is capitulum on the lateral side and trochlea on the medial side, lateral and medial trochlea. So this is the bone, right? And above that is anechoic cartilage. So essentially, if you look at this area here, if you can see my cursor, that's where you are. So if you're not able to see this nicely defined bony margin and overlying cartilage, you may want to ask the patient to extend the elbow a little bit more. So think of it like a sunrise view in the knee. In knee, you have to have patient flex as much as they can to expose that cartilage lined femoral trochlea. In elbow, if they extend, you are able to see this cartilage lined surface of the distal end of the humerus. So this is where your probe is, right at this level, to get this nicely defined bone and cartilage margins. So make sure you do that because some people are getting images, but they are not like very clear. You have diffuse hypoechoic signal either on the lateral or medial aspect, and that's because you don't have this nice maybe patient is more flexed or they are not extended enough to expose this articular surface. So that's important point here to add more extension if you're not able to see this type of image of your anterior elbow in short axis. And when there's something abnormal, you will not be able to clear it no matter how much elbow is extended. Even if it's 0 degrees, you will see a diffuse margin and the bone will not be nicely defined, and you may see some effusion or fluid collection here. Now, other structure on the anterior aspect is biceps tendon, and if some of you have attended mentorship or fellowship module, and we spoke in, this was covered in detail there. So now look at these anatomy images on the left. Biceps tendon is tricky, and you may require more than one approach to scan the entire tendon, and that's because of its fiber orientation. There are two types of band in the biceps tendon. and one has contribution from long head, other one from the short head. But look at the uh, band one of the tendon, and look at two. So it is turning and twisting in 3D space. So when you're scanning and you're trying to keep your probe long along the long axis of the tendon, um, at this point, somewhere where the biceps tendon goes posteriorly or moves posteriorly, that's where you start to lose the nice definition of the biceps tendon. And this is the reason, because look at the twist here of the band. So when you are long on the biceps tendon in the anterior approach, the first approach where you start from the belly of the biceps and then you follow the tendon distally to its attachment, if you are just parallel to the skin, you do get a little bit hypoechoic signal because of anisotropy. So what you have to do is do a heel to maneuver or push a little bit on the heel side so that you are parallel to the fibers and not just parallel to the skin, and you will be able to get rid of some of this hypoechoic signal. So if you see the left versus right, there is less hypoechoic signal on the right, because in this image the probe is oriented 90° to the tendon. So if probe is transmitting ultrasound which is hitting the tendon at 90°, you will see less anisotropy versus on the left side where the probe is parallel to the skin and it's not hitting the tendon at 90°. So that's anterior approach, right? In some people, you may be able to get the tendon to its insertion, the entire tendon. If they are flexible, they give you enough supination and you're able to see the tendon. That's good enough. But there are other approaches for biceps tendon that can be used to make sure that you have the tendon is intact. There is no abnormality towards the distal part, tendinosis, partial tears. You can see that. So after anterior, you can approach or you can scan the tendon with lateral approach. So this is an indirect approach, and it can be confusing. So even when we covered this in one mentorship module, some people have had difficulty with this because um, uh, this is a little bit of a strange technique because you're scanning biceps tendon, but you are not on biceps tendon. So it takes some time to get registered in the, um, um, in the mind. So this is the approach. This is as if you're on the lateral aspect of the arm. Uh, but what you're doing is you're aligning the probe along the long axis of the tendon. So you're trying to get a coronal slice of the tendon, if that makes sense. So if you look at the probe orientation here, this is how the biceps tendon is going distally towards the radial tuberosity, and you are on the lateral aspect and you're going through the muscle mass of extensor muscle mass and supinator muscle mass. So this is supinator and this is extensor muscle mass. So you are on the muscle part of the lateral elbow, and so your probe is resting on the muscle mass of extensor muscle mass and supinator, but you are aligned along the tendon. And because the elbow position is bent, biceps tendon is almost like along the long axis of the arm, and it's going towards the radial tuberosity, and there is some supination to expose that. So this is lateral approach. You can see the biceps tendon going down towards the radial tuberosity. There is a little bit of hypoechoic signal here, and you can get rid of it to a certain extent, but not completely, and that's because you have radial head and supinator here, and because of these two structures here, there's a refraction artifact, which unfortunately by maneuvering your probe on the outside you cannot get rid of that. So that's a drawback of this approach. Now after the lateral approach, medial approach is when you are again on the medial side along the long axis of the tendon. So here on the medial side, Although this is also indirect because you are going through the pronator, flexor pronator muscle mass, but when you put the probe there, you can feel the biceps tendon under your probe. On the lateral approach, on the lateral side, you don't feel any biceps tendon because you are much further away from the biceps tendon in lateral approach. Here in medial approach, you can feel the biceps tendon. So when patient is flexed like that, you know this is where the biceps tendon is, and you kind of like hook the probe on the medial aspect of the tendon. And so this is flexor pronator muscle mass, and that's the biceps tendon attaching to radial tuberosity. This is tricky because it can get slippery. It's a very thin, tight cord-like structure. You have gel there. You're trying to hook that tendon or really keep the probe in contact with the tendon, and your probe can slip. But if you can get this approach and get good at it, you can see very nice view of the insertion of biceps tendon. So this is a good approach um, if you can get more practice of this and get good at it. Now after medial, we have posterior approach, where you can see limited view of the tendon, and that's because you're going on the posterior aspect of the forearm. So this is the biceps tendon. It inserts on radial tuberosity, and so when the patient is doing supination, you are seeing more tendon on the volar aspect, but when there's pronation, it wraps around the radius and you see it like that. This is how you see the radial biceps tendon. I personally don't like this approach because it gives you very limited view of the tendon. Um, if you cannot find the tendon with anterior, medial, or lateral, go for this. But this is not a best approach for qualitative assessment of the tendon, because if there are any minor flaws, or let's say there's a partial tear or tendinosis or bicipital radial bursitis, you cannot see that in this view. This view is good if someone is doing guided injections, because on the posterior aspect there are no important nerves and blood vessels that you can injure, so this is a safe window for injection. But for scanning purposes, this gives you limited view. So now these are the approaches. So let's quickly review them again. So we did first anterior approach, where you find the biceps tendon in short axis, go long on it, keep the elbow extended, and ask the patient to supinate as much as they can, or maybe passively supinate yourself, and get the insertion of the biceps tendon. And this is how the biceps tendon looks like in anterior approach. If you see it, that's good. You can stop right there. If you're still struggling so much and it's important for you to scan the biceps tendon, then you go to the lateral approach. Remember, it's an indirect approach, so it's not going to feel like as if you are on biceps tendon, but you will see it through the window of extensor muscle mass and supinator, and this is how it's going to appear. Towards the distal end, there will be some hypoechoic signal here because of refraction artifact off of supinator and radial head, but you can see a good length of it. Now medial side, again indirect, but you feel the biceps tendon, so you are on the medial side of the biceps tendon, and you can see it inserting on the radial tuberosity. This is the flexor pronator muscle mass that you see on top of it. Then the posterior approach is when you cannot, let's say there's some type of complicated case and there's a lot going on and you really want to see if it's intact or not, you can use this. But don't go for posterior straight away, because some people like to go to posterior because it's easy, but it gives you only a limited view. So that's biceps. Okay, now let's go to the lateral side. Now again, it's very common pathology, tennis elbow, lateral epicondylitis, and many people are scanning lateral elbow, but they're missing the extensor muscle, common extensor tendon. So it's important you position the patient, have them sit down and rest their forearm on the table. Keep the elbow flexed approximately 90 degrees, like the way you see in the image here, and forearm in mid supination pronation, the way you see it. This gives you the correct alignment here, and then you palpate lateral epicondyle and you put your probe along that long axis. So your lateral epicondyle should be on the left side, and you try to get the image where you can see the lateral epicondyle, this nice bony contour here, elbow joint, and then this is the radial head. So you want to see the lateral epicondyle, radial head, neck. That's when you have the good view of the tendon. So bony landmark, very important in ultrasound, and this region is very important because if you get this bony configuration, this bony arrangement, this bony landmark, you will definitely get the tendon. But if you don't see this arrangement, then you don't see, because this is how the tendon is arranged over these bony landmarks. So if you get the bony landmarks, you get the tendon also very well. Now here you can see the common extensor tendon. There is lateral collateral ligament or radial collateral ligament, which also blends with the common extensor tendon. So here the yellow arrow is pointing at radial collateral ligament. It is also shown here in this view between the arrowheads and the arrows here. So this is the footprint of the radial collateral ligament, and again it goes here, wraps around the head, which again, like, remember, if the very first image is, in this presentation, annular ligament and the radial collateral ligament was blending on it. I'm going to quickly go back and show you that. See, this is yellow one is radial collateral ligament, and the blue is the annular ligament, and you can see the fibers going here. So that's what we are seeing here. So these fibers, and they go over here. So, but it blends. There's when you study cadaver, you cannot tell the difference between the texture or the color of the tendon and the ligament underneath. You know them because where they're attaching. So ligament is going to go from bone to bone. That's how you know this is radial collateral ligament. Right overlying that ligament is the tendon, which is going from lateral elbow, lateral epicondyle, and then individual fibers are going to go into different extensor muscles, whichever muscles they are part of. Now, another structure that you want to notice, note here, is this triangular structure here, which is lateral synovial fringe. So you get to see a little bit of synovial tissue here. So this is the lateral synovial fringe. So you're looking at intra-articular tissue here, ligament here, and the tendon here. So in nutshell, if you get a good bony landmark, which is what you see here, lateral epicondyle and radial head and neck, and you see parallel fibular arrangement, try to get as best as you can get this arrangement. If you get this, you're looking at the tendon and the ligament and also some of the lateral synovial fringe in this view. So make sure you get the bony landmark correct for this view. On the medial side, common flexor origin tendon is short, very short, and so you see a little bit of tendon over the medial epicondyle, and right after you will see the muscle mass. So it's a much smaller and shorter tendon on the medial side. So you can have the patient flex the elbow, and if you change the alignment of your probe, so let's say in this view you have long axis view, one end of your probe is resting on the medial epicondyle, and so you're seeing the common flexor origin tendon and the muscle. If you just move the heel, if this is the heel part and this is the toe part, if you only move the toe part of your probe, you join this part of the ulna, you can see anterior band of ulnar collateral ligament. So so unlike on the lateral side, you get everything in one view. On the medial side, you may have to change the alignment a little bit without losing the medial epicondyle. If you bridge the sublime tubercle, you can see you can see the anterior band of ulnar collateral ligament. So that's the medial. Okay, now so that's all with elbow. Just wanted to address some important key points, but if you have any questions, we can take them right here. I'm going to start ankle next. So if you have any questions on elbow, let me know. Okay, I take that as no questions.
Mohini?
Yes.
I remember, so it's been a while, but I had a kid that was a young boy that had a little leaguer's elbow with the medial epicondyle. Can you review where that, like, what the view I need to take is on that, like, exactly to see
I
that?
think you
Because
had the correct view. That's how we found it out. Yeah, I think you had the correct view. In that, I remember that case. Yeah. So
okay, I
you,
was thinking maybe it's the dynamic that I'm questioning in my mind, because we had to do a dynamic view to gap it.
yeah. So little leaguers, yeah, you need to have the tendon and the medial epicondyle very well in that. So if you have medial epicondyle and the fibers attaching there, that's good enough. Like I said, you may not be able to see the ligament very well in the same view, but I think you had multiple views in that area. So in some views it was easy to see the tendon, and some views you had a good view of the ligament itself and the joint itself. So as you can see, this is where the joint is, right? So ulnar collateral ligament anterior band is going to start from here, and it's going to go. It looks a nice hyperechoic band, and it will attach somewhere here, the sublime tubercle of the ulna. So it has to cross over the joint region. So if you're trying to capture different structures of the same region, you may have to change your probe a little bit, not like whole lot, keeping the important key bony landmarks in the view. Yeah, so does that answer the question?
Yes, thank you.
Okay, good, thanks. Okay, Mark is trying to unmute himself, and I don't think I have muted you, Mark. It says self-muted. Oh, no, you're good.
Oh, yes, it says I'm unmuted now. Can you hear me at all?
Yes.
Oh, good. Okay, that was it. I've just never
That was
spoke, so I was just
okay.
checking to see if it worked.
Okay, good. So let's move to ankle now. So I have the reference here. So this is a good article, and they have summarized it. So I thought it's a good. I have this for different views of the ankle, different placement of the probe. So let's review the important structures that we scan when we do ankle ultrasound. So number one is anterior tibio-talar joint or ankle joint. So your long axis on the ankle joint on the anterior aspect, and you're looking at the joint. So you look at tibia and talus and synovial fluid, and you're looking for any extra collection of the fluid there or any synovial hypertrophy. And then structure number two is anterior tibio-fibular ligament, and number three is anterior talo-fibular. So they're both ATFL, but one is tibio-fibular, the other one is talo-fibular. Now, if you remember from the module, I always say make the V, right? So this is kind of a V here, 2 and 3. The reason why this does not look like the V that you see on the module handouts is, remember, you have to have different positioning. So ankle is plantar flex and is inverted for the scanning. So if you do that positioning, this is going to be more of a V, and so the angle will be much more So this will go a little bit more down towards the talus. So make that V, start with anterior tibio-fibular ligament and then go towards the talus without losing the fibula. Remember, this is your fulcrum. Lateral malleolus or fibula is your fulcrum. So you get the tibio-fibular ligament, and without losing this part of the bone, you turn and you keep moving the other part of the probe to bridge lateral malleolus with talus, and that's how you get talo-fibular ligament. Now on the posterior side, you have peroneal tendons and calcaneo-fibular ligament. They have inverse relationship. So peroneal tendons run on the lateral aspect just behind the lateral malleolus, and brevis attaches to the base of fifth metatarsal, and longus goes on the plantar aspect to attach to the base of the first, and it has other extensions towards the medial side of the foot. So that's the anterior lateral region. So if you scan these structures, you have checked anterior and lateral aspect of the ankle, right? And these are important structures, most commonly affected structures. Now here, calcaneo-fibular ligament, you have to bridge fibula or lateral malleolus with calcaneus. Now when you are short on peroneal tendons, you're long on the ligament, or when you are long on the ligament, you're short on the tendon. So there's inverse relationship. So if you follow the peroneal tendons in short axis view, at one point you will be long on the ligament. You can see it. Now you can ligaments we scan in stretch positions, so you have to have patient in dorsiflexion to stretch it. You can do that passively, and that will give you a better view of the calcaneo-fibular ligament. On the posterior side, you have Achilles tendon. Mainly we image that. Now there in this article they have flexor hallucis longus tendon, and the reason why they have it here is because this tendon is very close to the posterior recess of the ankle joint, and that's why it can get affected secondary to any joint problems or any joint pathology or bony abnormality or anomaly like os trigonum. When there is a little bony ossicle of talus on the posterior aspect, it can rub against the hallucis longus tendon. Now, although the probe positioning is showing you flexor hallucis for flexor hallucis longus, your probe should be medial, and it looks like as if you are on the Achilles tendon. It's not the true representation of that. So Achilles tendon is, it's very easy. You can be long and short on it and cannot mistake it for any other tendon. For flexor hallucis longus, you go a little bit medial to the Achilles tendon, so you're not on Achilles tendon. Go a little bit on the medial side, so basically the posterior aspect of the tarsal tunnel, and you're trying to look for a tendon which is the deepest and closest to the joint. And I have an image of that coming next, but let's go over to the medial side again to go over all the important structure that we image before that. So now we are on the medial side. So let's go back. So we did these structures on anterior and lateral. We move posterior. Now we are on the medial side. Now medial side, they have defined this as area of anterior portion of deltoid and posterior portion of deltoid, and posterior medial tendon group, which is also tarsal tunnel structures. And this structure, FHL, is essentially a structure or a structure that passes through tarsal tunnel. So this is included in this aspect here. So it depends, where you're reading it from, which journal, what type of reference. They'll use different terminology. What you need to understand is there are some structures they can be included on the medial side or the posterior side, but as long as you image the entire aspect, So you have at least one structure on the medial, lateral, anterior, posterior, and important structure which are important for the patient and for the purpose of the scan. That's what makes the scan more appropriate for the patient. So you make sure you cover those structures well and make it more tailor-made to the patient need. So now I'm going to explain you further why they have divided this like that. But let's go by the structure that we scan. So on the tarsal tunnel, we scan tibialis posterior, flexor digitorum longus, flexor hallucis longus, artery, nerve, and vein on this area. And then you go a little bit further distal, and there are two regions: anterior deltoid and anterior portion of deltoid ligament and posterior portion of deltoid ligament. If you remember, we scanned three parts of it: tibio-talar, tibio-calcaneal, and tibio-navicular. So this one would be tibio-talar, and this one would be tibio-calcaneal. So that's what they mean by anterior portion and posterior portion here. Now, let me go here. Okay, so this is the posterior portion on the medial side. So that's the ligament here, and you can see a single. So this is the posterior deltoid ligament region. So this is the posterior deltoid ligament region, and overlying this area is tibialis posterior tendon. Okay, and going to anterior deltoid ligament region, you have an anterior band of deltoid ligament, and you can see the posterior tibialis tendon here. So that's how they have divided it. It may not mean that it may not be important for you to divide the area like that, but if someone is more concerned about specific pathology, at what level the deltoid ligament is affected, or where do you see posterior tibialis pathology, you can define these areas by that. So it doesn't mean that you have to define every case of ankle scan that you do based on anterior deltoid ligament region or posterior deltoid ligament region. But you can see here on the anterior side, the fibers are bridging tibia with calcaneus here, and here you can see tibia and talus here. So tibio-talar is posterior and tibio-calcaneal is anterior. Now let's review the other structures now. So let's go by, this is what we did, the anterior placement, right? So let's go by these structures. So this is the anterior joint. You have tibia here and talus here. They have different orientation here. Proximal is here, distal is here. So this is the joint region, and this is fat pad. This is a blood vessel here. Sometimes you can see a little bit of intra-articular fat pad also, which you are seeing right here. So that's what you see on anterior joint space. Now, first ligament on the anterior lateral side, anterior tibio-fibular ligament. So this is the ligament here bridging tibia with fibula. This is how the ligament is. There are different fascicles here that you scan. Actually, you can go from inferior to a little bit on the posterior fascicles. So even when you see someone with the rupture of anterior tibio-fibular ligament, it seems like a complete rupture. Make sure you go a little bit proximal and distal to see if the other fascicles, some of the fascicles are still intact or not. Most of the time there are. It's not, because there's a continuation of interosseous membrane also going a little bit more proximal. It's the Talo-fibular which is most commonly involved and more likely to rupture completely. So, and underneath this ligament here, you can see, sometimes you can also see some vasculature here, small blood vessel there. Now, from here we make a V, so we keep the one end of the probe on the fibula and make fibula as a fulcrum, and from there go distally towards the talus. And this is how anterior talo-fibular ligament appears on ultrasound. So you're bridging fibula or lateral malleolus with talus, and that's how you see it. You can also see a little bit of joint space here, or sometimes you can see joint fluid underneath there. That's anterior talo-fibular ligament. Now, lateral side, you have calcaneo-fibular ligament. Remember, there's inverse relationship of calcaneo-fibular with peroneal tendon, so that's longus and brevis, and this is calcaneo-fibular. So here you can see this is calcaneo-fibular ligament, and that's peroneus longus and brevis. Okay, all right. Now let's go next. Now this is example of peroneal tendinosis. So here, which one is longus and which one is brevis? Peroneus longus and brevis. So you can see one tendon here, there's another one here. So if this is tendon number 1 and this is tendon number 2, which one is number 1 longus or is number 2 longus? Which one? 1 or 2? Is anyone paying attention?
Yes, I'm going to say 2 is longest.
2 is longest.
Yeah.
That's what I would say.
2 is longest?
Uh-huh.
No, 1 is longest.
Which one is 1 and which one's 2 again?
1, this is 1 and this is 2. So
The reason I said that is because the bulk of the muscle on longus is usually more proximal.
yeah, so we are at the tendon level, so we don't see much muscle here. So this is tendinosis, right? So this is an abnormal image. But when you are looking at the tendons right at the tip where they start to turn anteriorly, remember the hamburger type of appearance of these tendons there? Brevis is always closer to the bone. And that's why, yeah, that's why when you have split tear of brevis, the longest drives in between the two.
Does it have
So-
anything to do with the the brevis being a little bit more hyperechoic and seeing a little bit more muscular type fibers of the longus, or not really?
In this specific example, or you're talking in general?
Oh, probably in general.
I'm
But-
not sure about that. Not sure about that.
Okay. I didn't know if it. Okay. But it's because
Yeah.
it's closer to the bone. Okay.
Yeah.
I just remember that now, that the brevis is closer to the
Bone, yeah.
to the bone.
Yeah. So here there's tendinosis. You can see focal hypoechoic. There's also a little defect, so probably some intrasubstance tear, but there's hypoechoic signal here in long axis. If you follow the tendon distally, you can see it's hypoechoic. You don't see normal fibular pattern. So that's the long axis view of peroneal tendon. So this is peroneal tendinosis. So now if you have fluid around it, so if there is anechoic or hypoechoic ring around it, and you can see tendon as hyperechoic. So if you take this texture, for example, this one here, this looks normal, right? So let's assume that longus is also of the same echo texture like this, and you can see normal tendon, but you see hypoechoic or anechoic ring around it, and you go long, and again you confirm the tendon looks bright and fibular, but there's hypo or anechoic signal around it. What would you call that? That pathology would be called what?
Tendinosis.
Tendinosis.
So this is tendinosis, this current example here, because the tendon is hypoechoic in short and long, You don't see normal fibular pattern. It's not hyperechoic, it's hypoechoic. Dark,
Hypoechoic.
right? So this is tendinosis. But I'm saying, let's assume that you see normal hyperechoic bright tendon in
Synovitis.
non-start, yeah, tenosynovitis, yes. So tenosynovitis is when the synovium that surrounds the tendon is inflamed, and tendinosis is when the tendon substance itself is swollen, right? So
Mm.
that's the difference. So that's it. So if the tendon is involved, it's swollen, hypoechoic, abnormal looking, that's tendinosis because something is wrong with the tendon tissue. But when the sheath or the synovial sheath that surrounds the tendon gets involved, that's tenosynovitis, right? Now there are some tendons in the body which do not have tendon sheath, like Achilles tendon. So you will not see tenosynovitis of Achilles tendon or distal biceps tendon. In that case, if you see, but you may see hypoechoic or anechoic ring around it. In that case, you are going to suspect some type of bursal effusion.
Mm-hmm.
So the tendons who do not, like the tendons where you do not, you know that those tendons do not have tendon sheath, you're thinking about bursa in those cases. So so although the presentation or on ultrasound it may look similar to tenosynovitis, but you don't want to call it tenosynovitis because by the knowledge of anatomy that this tendon does not have this type of tissue around it. So this is some different, so what I'm trying to do is like get you thinking. So you may see similar picture in different tendons, but doesn't mean that they have the same pathology.
The most clear one I've seen recently was in a de Quervain's that had that really hypoechoic ring all the way around it.
Yeah, that is usually very classic. Yeah, de Quervain's is a very good example. Yeah. Okay, Brian is saying, did you possibly do a color image of peroneal tendinosis? Yeah, I would do this. This is not my image. Like this is from this article here. Yeah, if this was my patient, I would definitely put a color Doppler here. Yeah, I'm sure they did too, to see any vascularity here. You should use color Doppler for everything. There's no harm in overusing it. I don't think there's any harm in overusing it. Okay, so now let's move to the next structure. So flexor hallucis longus. Remember that image on the posterior side from Achilles tendon. If you move a little medial, so towards the tarsal tunnel, this is the last tendon. Tom, Dick, and Harry. So this is the Harry of tarsal tunnel. So this is the tendon here, and as you can see, it's overlies the posterior joint. So this is tibia, talus, and it's going over the posterior recess and between, this is navicular and this is calcaneus. So in cadaver image, this is the tendon here, and that's the figure here. And this is not the best ultrasound image. I'm sure you can get better image here, but because this is from the article, so I put it here. You can see the tendon going over the bone here. So why this is important, tendon, especially someone with joint pathology, inflammatory arthritis, rheumatoid arthritis, or any type of inflammatory arthropathy, this can get affected secondary to joint involvement. Or if someone has a little bony ossicle coming off of talus in this area, let's say, and it's rubbing against the tendon, that can also cause secondary tendon problems. So it's important to know that this is right above the joint area. Now, okay, we did this. So here on the medial side, going a little bit more distal over the deltoid ligament, you can see the posterior tibialis tendon right overlying it. And these two are the other tendons of tarsal tunnel, flexor digitorum longus and hallucis longus. And that's anterior, a little bit more anterior. And this is tarsal tunnel. Now this is a little bit of different view, but this is how you see medial aspect of the ankle, tibialis posterior tendon, flexor digitorum longus, artery, vein, nerve, and hallucis longus. Now here what you see next to the tendon is the muscle part. Digitorum and hallucis are always accompanied by a little bit of muscle tissue also in this area. But if you follow these tendons a little bit more distal towards the toes, the muscle part is no longer there. So by the time you move into the tarsal tunnel towards the distal end, you will not see much of the muscle. From that point onwards, it's just the tendon. But in the tarsal tunnel area, you will see some muscle tissue, some tendon tissue, and that's why it gets confusing, because if you have a little bit of tendon tissue and rest of it is muscle, and look, this tendon is so close to the nerve, and because nerve is hyperechoic in ankle on the medial aspect, this can be confused with the nerve, because echo texture can be very similar. They are both hyperechoic structures, compact, round, oval-looking structures, and especially with a good contrast with the muscle, it can give appearance of a nerve. So, so when you're scanning in ultrasound, it's good to know what structures are adjacent to it and what's their relationship. So if you have someone with some anomaly, you should still be able to say what is what, which structure is which structure. Okay, let me see. Oh, that's the last one. Okay, any questions? That was the last one. Anything that you want to discuss, add to it, any questions? No questions, I guess. Oh, somebody's typing. Oh, great presentation. Thank you, Brian. Okay, I guess that's all. Thank you,
Thank you,
everyone.
Mohini.
Yeah.
Thank you,
Okay.
Mohini.
Good night.
Thank you, Mohini.
Mohini.